sort of created a model to help explain how TPIRC's oral immunotherapy process works. So hopefully that'll help explain some of the differences and the benefits in our view. So TPIRC, we're calling it TPIRC's OIT University. It sort of replicates a university model in a lot of ways. OIT University strives to address the growing life-threatening food allergy epidemic by providing oral immunotherapy to hundreds of pediatric patients, building on the 99% success rate achieved by Dr. Randhawa in about 10 years' time. And there are 4 basic pillars of the people connected with the university. The first includes you all, prospective and newly enrolled candidates. Then there's the currently enrolled candidates, the people who are actually having to do the dosing. And then there's the graduates and the alumni network, where all of us hope to end up. And then this last pillar, equally important, is the research and collaboration and advocacy arm. So let's talk a little bit about what OIT is. OIT, which stands for oral immunotherapy, is food-based immunotherapy for food allergy. It's very comparable in a lot of ways to allergy shots, which many people are familiar with. They're injections under the skin of increasing amounts of typically environmental allergens. It's done over time to induce tolerance. And they've been safely and effectively used for almost 100 years. So they're widely recognized as a suitable and effective treatment. Notably, they're not FDA approved. I always found that fascinating. OIT, like allergy shots, uses a specific standardized dose escalation, but in this case it's a whole food product like peanut or egg, what have you, over a period of time to induce desensitization of that food. And there have been many studies that show that once patients have gone through the process, if they take a maintenance dose after achieving their desensitization, they'll remain tolerant, and in some cases they can eat their allergens freely. And with the TPIRC OIT model, that's the goal. TPIRC's program is able to achieve that by reaching a higher maintenance dose, and the goal is to, rather than having a higher maintenance dose eaten daily, it's less often, weekly or even monthly in some cases. And that allows patients to eat a normal U.S. dietary intake of that food, giving them true freedom. So I'll break it down a little bit and talk about the differences on each of those 4 pillars. So the first pillar are people like you, newly enrolled and prospective patients and candidates, people who are thinking about starting, people who are on the wait list. First, as I mentioned, TPIRC provides the most complete pre-OIT diagnostic testing. So more than just a blood draw. It's component testing. It may include a patch test, a skin analysis, lung functioning test, gastrointestinal exam, immune system, and of course this would depend on your child, but anyway, it's a complete set of tests. There also will be potentially prescribed some pre-OIT treatment if your child has underlying conditions that are connected with allergies. For example, asthma, environmental allergies, sometimes people have immune system irregularities, eczema, things like that. TPIRC is an open access clinic, does not restrict the patients that it sees. So if your child has experienced anaphylaxis, they're not excluded from this program. If they have asthma, they're not excluded from this program. There may be extra steps that need to be taken to get them ready to make it safe and successful, but no one's excluded. And TPIRC is able to offer treatment for more foods than many other places. We've listed peanut, tree nuts, milk, egg, wheat, soy, seeds, fish, and shellfish. And of course, there's educational and mentoring programs like this and more along the way. For currently enrolled patients, we'll be offering a customized strategic use of medications. This allows people to reach their dose goals while minimizing reactions, which is really important to the success of the patient and their sense of well-being. As I mentioned, all the treatment is done at Miller Children's Hospital. Patients are monitored by a physician and an RN, respiratory therapist, and there's emergency facilities on site, just in case. TPIRC has a decade of experience, nearly a decade of experience in OIT with more than 6,000 successful food challenges and a less than 1% incidence of EpiPen use during treatment. I'm not sure what the EpiPen usage is out for people who haven't undergone treatment, but it's got to be higher than that, and most people don't use an EpiPen when they need one. So it's very safe. And we recently learned that TPIRC has more tree nut, shellfish, and fish OIT patients than anyone else in the world. So it's really doing a lot. And again, there'll be ongoing support in events like this. For graduates, the exciting news is Dr. Randhawa has an unmatched 99% success rate for people who follow his protocol. The larger maintenance doses are more convenient for patients, and they also increase safety, improve their compliance, because try giving a 16-year-old a daily dose, it's challenging, and allows graduates to consume more, as much of the food as they want, like anyone else. And the ultimate goal is to induce immunological tolerance, meaning the IgE is actually 0. And for researchers and collaborators, doing a lot of research, I've listed some potential areas of interest, looking at biomarkers, cross-reactivity. This will be a site for some clinical trials, LEAP study and peanut capsular 2 that are coming up, and we'll be providing opportunities for researchers and physicians to utilize our research facilities.
One of the things that I think is important to discuss, because I know you're all on Facebook, right? How many people are on Facebook? I'm just curious. Everybody? Wow, that's impressive. Not everybody. I've generally found about half my patients are not on Facebook. But, I think it's important that everybody recognizes, everybody comes from a different part of this community, right? The community is food allergy community, but there's really some kind of different groups that are there. And I kind of always ask these questions indirectly often, but I generally break it down like this, where, there's group 1, which is the new diagnosis patients, right? And you've all been through this. First anaphylactic episode, maybe epi's given, maybe not. Episode's not, horrible. Age can vary. Typically it's under age 5. You're not sure what to do, right? You're kind of given this mixed message. You go see a doctor, you go see your pediatrician, they run some labs, and they say, you know what, maybe, keep your fingers crossed, your kid's gonna outgrow this. But on the other hand, here's this life-saving adrenaline shot. Good luck, right? So that's an odd message, right? And then, so few changes are made to your lifestyle. It's kind of hard to know. What do you change? What do you do? You stop going to baseball practice? Do you, what do you stop doing? And then that child has a second reaction, right? And that second reaction is the eye opener. And you start to say, wow, that was scary, because usually the second reaction is pretty significant. May end up in the ER, may end up in the hospital, typically epi's dosed, and it puts parents and families in this defensive mode. They're kind of they're much more, you have to watch things much more carefully. Often demand school adjustments, join organizations, etc. And that's a good thing. So the problem is the same child then has a third reaction despite all that, right? And and this is a very common story. At that stage, what most of the families, at least that I've seen, do is they go into almost this, reclusiveness or this isolation. The families are doing all the cooking at home, they don't go out, kids are often homeschooled, things of this nature, and I often hear this term, their family existence is limited. And that works, to a degree for years, and then many times they still have another reaction. That usually happens at church or at grandparents' house or something of that nature, and then they're in a very difficult place, right? Because they have failed standard of care, right? Standard of care is, hey, you carry this EpiPen, you avoid the foods, you do all your label reading, and your child will be fine. Well, it didn't work, right? So when I first started, all my patients were down here. I mean, I'd say almost all of them were really in this kind of fourth category. Now they're kind of a lot of 3s and 4s. I have some 2s, and I have very few 1s, But keep in mind, this is your community, right? So everybody comes with that different background. But what brings people together here are these same 2 issues. You want some kind of treatment, and you want to keep your kids safe. That is really what brings everybody together. So, as Katie alluded to, what is the issue, right? Why is this not happening? Why aren't we treating more kids? Why is this not more popular? Well, the academics, the people at all the big universities, and that's me too. I'm on faculty at 2 very large universities. when I talk to my colleagues, they basically say, we don't have enough evidence out there. Well, okay, they say we have enough evidence that it works, but we don't know exactly how to deploy it to a large population of patients. So they just kind of back off. They run few clinical trials for OIT, and I will tell you that in the next 5 years, you will probably see fewer clinical trials of this type of OIT because the funding is simply not happening. And then a handful of private practice doctors offer this. And I know that number is growing. I get emails from a large number of private practice allergists on a regular basis asking, what is my protocol? And my answer to them is, it's complicated, right? Because if you're treating every patient individually and you're trying to put them into large subgroups, I can't exactly tell you, here's a recipe to follow, let's hope it works. So that is why it's important to do this the most scientific way, which is you publish your data, you follow your outcomes, and you follow these patients for a long period of time. So you're basically looking at academics who are kind of now standoffish, private practice doctors who are really don't have a consensus on how they're doing this, and now the FDA will not approve any sort of treatment unless it's a pill or a patch. They will not approve individualized protocols. These are called PSPs, patient-specific prescriptions. Whether it's shots or certain types of cancer therapy, they will actually not FDA approve this type of therapy. So now, where does that leave us? We're going to be conducting some of these trials here. The patch and the pill are interesting, but what is the yield on those? It's going to lead to some major questions, and major food allergy organizations are really not going to support this type of OIT therapy. So basically, it's a lot of mixed messaging, and I think the community that I see, at least when they arrive here, there's a lot of confusion. There's a lot of things said. You talk to your allergist, your private practice allergist, your doctor, and they're not sure where this all should be said. So I'm hoping by the next 40 minutes, 30 minutes here, I can try to clarify where we're at with this, and you can see some of the results. So before you ever undertake any kind of therapy, the smartest thing to do is to do a risk-benefit analysis. It's just that simple, right? What is the risk? The risks are many. One risk is, accidental exposure. You don't pursue any treatment, what is the risk of an accidental exposure? I don't need to go into any details on that. You know it happens. We know the media press is big on this. We had 3 deaths just a month ago. I mean, this does happen. It's unfortunate, but it does happen. About a third of patients who have already a known food allergy will undergo anaphylaxis every year. I mean, I had one allergist tell me that his expectation is it's okay to undergo anaphylaxis once a year. Once a year is okay, but not 2. And I was like, well, what's it? Anyway, but again, this is one of those things, right? What is acceptable? What is considered standard of care? Obviously, there's a large number of patients who go into anaphylaxis and visit the ER. On the other aspect of risk is, what is the risk of reactions during OIT, right? And we'll talk a little bit about that. Obviously, this protocol that I've designed here has a very, very low level of risk, but again, it takes effort to develop those things. And then the long-term question is, can OIT cause other medical problems? And that's a very legitimate question. We don't have 10-year data anywhere. Nowhere in the world has anybody studied these patients for 10 years. So, do we believe anything's going to happen? Well, when you're practicing, I call it the edge of medicine, you have to look at other forms of immunotherapy, right? I published one of the first articles where we used other forms of immunotherapy on HIV patients. And their T cells and their immune system obviously is complex. And we were able to successfully do this in those types of immune systems. I firmly believe that if we look at other forms of immunotherapy, we know long-term success is there. We know long-term risk is not present. So I don't believe that there's going to be an issue 20, 30 years from now. But that's why we need to follow the safety and follow the outcomes. To do this in an unorganized way, really, I think it puts our kids at risk. The benefit, obviously, to this is huge, right? I mean, absolutely huge. Top safety potential. Katie can talk about it. I'm sure you if you're on Facebook, right? It's amazing. It's really neat, and this is something that if you get a sense of what the other conditions I treat in TPIRC, it's not something I really expected to understand, but I get it a lot more now. My patients who are out 5, 8, 9 years, just very different people, very different families. Just the lifestyle is vastly different. Long-term safety is maintained, and I believe there's this potential to achieve tolerance. Again, this is why we need our data to collect over time. I'm going to run through this very quickly. This is all in our FAQs, but I think it's important that we distinguish what is this TPIRC model and center versus typical private practice versus the clinical trial setting. So remember, number one, clinical trials are valid. They're good. I've run 26 clinical trials here in the last few years in various diseases. They're always done in a research facility, but often conducted by non-MDs. They're called CRCs. These are research coordinators who are typically nurses, but in that setting, typically it's a non-MD who's actually dosing those doses of food. In the private practice setting, often again, because it takes time. You know, the allergists have to see their volume of patients, so they're going to have a nurse or somebody else kind of pop into another room and just kind of give the kid the dose, and they do this on a weekly basis and so forth. With us, you know, again, thanks to a single family who really was able to launch this thing a few years ago, you know, we have physicians, we have nurses, we have respiratory therapists, we have a whole staff of folks who are on site. And we have I just don't think it could get any safer than where we're at. Once you actually walk into our center and our clinic, you know, we've been fortunate that we never had to use it, but you push a button and you'll have literally a team of 8 individuals down there, a code team, and they'd be ready to do whatever is necessary at that stage. I believe that is a very big positive for our center. Risk of adverse reactions. This is something I want to make very clear. Pure clinical trials mandate that you put every kid into some form of anaphylaxis before they start therapy. Right, so we're gonna. I mean, I'll just might as well announce it now. The Ammune pill, peanut pill. We're going to be conducting that trial here in December. Now, the protocol is very clear. It says that we take the children in, we have to put them into anaphylaxis. We give them enough of a dose, and it's called an eliciting dose. We write down that eliciting dose, and the patient goes into grade 1 anaphylaxis. May have to use epinephrine. Often is used. And then the patient is started on treatment, or placebo. That treatment is continued for a period of time, 6 months on maintenance in this case. And at the end of that time, we give them enough peanut again to put them into anaphylaxis one more time. And that is done to figure out the academic difference. What was your initial eliciting dose, and what can you tolerate down the road? That is necessary for FDA approval, right? That's why this type of thing is done that way. Now, I used to do something very similar 8-9 years ago, and I just essentially stopped doing it because it didn't make much sense. If I have enough evidence that a patient has a clinical history that's positive and I have multiple objective parameters telling me the patient is positive, I don't need to do the first eliciting dose. But when we're done with treatment, we're hitting such high doses, those doses would pass anybody way beyond anything seen in these trials. So there's no need to do a second dose in that sense because you're actually way over and above achieving those goals. Patient access, obviously, we're open. Katie already addressed that. Cost, we do our very best to minimize cost. I mean, we, frankly, for the types of testing we run, all of the difficulties that come with that, prepping tests, the nursing staff support, et cetera, for what we do, I mean, we have a lot of patients where we bill and things don't get paid, and we just write it off. Now, we're able to do that again because of the one family who initially supported us, but this is why this center, if it's going to continue to exist, it will need ancillary support and funding. A couple quick points. I always try to understand, when I see any patient, what are your goals of therapy, and what perspective are you coming from? Like, what have you seen, and what are your goals based on what you have seen? A lot of folks come in, and some of them say they just want to be, quote, bite-proof, right? Their child is extremely allergic. They only want to just be able to tolerate a very small amount of food, 1 peanut perhaps, or something of that nature. Some of them want a daily exposure to just a small amount of antigen, just in case there's an accidental ingestion, so that if an ingestion happens, it's just a minimal amount of symptoms. Some people want free eating, which is a term I've only heard in the last couple of months. I'm not sure what that means, but I mean, free eating is like a buffet, right? It's like that's not free, but but what does that mean long term? These are questions to be asked. Is a small daily allergic food exposure just do that basic minimum, hoping a drug will pop up in the next 5 years? I've had people come up with that perspective. Is it done to help the anxiety of their child? I've seen that a lot in teenagers that we've treated. To reduce school or college risk or exposure. So these are what I've seen from patients. I think understanding, number one, that OIT is not a cure. Fundamentally, it is something that we are trying to achieve long-term, right? We're trying to achieve this long-term safety and long-term induction of tolerance. Let me tell you my perspective, right? This is my perspective and my goals. And, CJ was asking me earlier, why are you doing this? Which is a good question, right? Why? My kids don't have food allergies. I didn't really, you could tell I'm a pulmonary doctor. I do a lot of other things, right? So, I got into this because I saw a lot of bad things about 9-10 years ago. I saw a lot of fatalities in the ICU, and it just bothered me. It was just that simple. And so when you see these cases and you see what happens, and to me, this is such a preventable thing. If there's a way to fix it, I have an obligation to do so. That's kind of my perspective on things. So when I think of it that way, imagine that I deal, with ICU patients who've had extreme reactions. You can understand why if that's my perspective, my goal is ultimate safety, right? So I do try and get patients to achieve pretty high doses of food, pretty high maintenance doses, so that they actually can manipulate their immune system over time and lower that maintenance dose down to once a week or even a couple times a month or once a month. I have a number of patients who are on every 6-week dosing even. Annual follow-up testing, we need to continue to monitor that immune system over time, and they still carry their EpiPen, because again, we don't know, right? We don't have 10, 20, 30 years of data to say we should not do that. And the endpoint goal is to eat a normal US diet, incorporating all of those previously allergic foods with no ceiling or cap on that amount of food, right? So, quick story. I had a large number of patients who finished clinical trials at various centers across the country. If they're teenagers, they will often stop eating their food, right? So they pass the challenge. The parents are under this impression that, I shouldn't say challenge, they hit their maintenance dose. They're under this impression that they're, quote, cured. Their child's 13, 14, or 15 years old. Jimmy, make sure you eat your peanuts. Yeah, I did, Mom. Dumps it in the trash, hides it in the sofa, whatever. 2 weeks goes by. Jimmy eats his peanuts in front of his parents and goes into anaphylaxis, gets a couple epis, ends up in the hospital. Actually has a worse reaction than he had before he ever got treatment. So the goal has to be very, very clear, right? We need a dose that's high enough to create maintenance dose that's high enough to induce this high level of desensitization, but infrequent dosing enough where you can ensure compliance. And like I always tell folks, if your child's going to college and you got to Skype them once a month and say, I need to watch you eat that. Hey, you know what? If that's success, then that's success. It's just that simple, right? You know the numbers. About 2.7%, based on a large meta-analysis of patients, can develop EOE. I have not seen that. I've not seen patients. In fact, I have patients who have EOE who go through similar treatments, although uniquely different, and they do very well. So obviously the risk is there. The other issue is epinephrine use at home, and I will tell you in all the years I've done this, and I don't know the permutation numbers on how many doses have been given, it's I don't know, 500,000 doses given at home or something like that. Epi's been dosed 3 times, twice by the same mother, and once by this other individual, and the children on both ends were just fine. Their complaint was, I have an itchy throat. So it was fine, it's okay. But we've never had anything more significant than that.
What's the EOE?
Oh, sorry, it's eosinophilic esophagitis. So it's a form of gut inflammation caused by a cell that is kind of an allergic cell. And it could be pretty significant. EOE is, they're almost like, it's like a Venn diagram, right? So like there's a whole bunch of patients who have EOE who do not have a food allergy. And then there's a bunch of patients who have food allergies and don't have EOE, and then there's a very little cross overlap. But it is something that gets a lot of press, and a lot of people bring it up as a question. So other things that are an issue for safety are, missed doses. It's very important that people communicate with us. I think one thing that I'm very proud of is we give people pretty much open access to us, 24/7 call, any issues pop up, it's not hard to get a hold of us. And on top of that, we give people a very, very, very comprehensive anaphylaxis plan. So, I'm very, and I think that's why we've had, again, a very good run of success, and we've not had any major reactions. So our highlights again are the same. I tried to update our numbers since the August event, and this is around where we're at. We're actually a little higher than this now. So 812 treated, lots of challenges, bunch of visits, obviously. We're hovering around 300 peanut graduates. and the rest of the numbers are there. So we're doing very well. We're at a point where probably in a year we can be around 1,000 who've been treated, and hopefully our numbers stay as successful as we've been.